webinar that takes a look at our community health needs assessment and our health improvement plan process. So thank you all for joining us today. I know we have some hospitals on our call today. I know we have other partners like DPH partners, other nonprofits, and other organizations who play a role in the community health needs assessment and improvement plan process. So today's webinar, from assessment to action, leveraging RBA to strengthen community health plans. So we have a great lineup today to give us an overview of RBA, how it's utilized in practice. So next slide, we'll hop into our Mentimeter question. So we want to know, how familiar are you guys with results-based accountability? So if you're not familiar with it at all, then I think that's probably going to be a 0 rating. If you're pretty familiar with it, then you're probably higher on the scale of familiarity with RBA. So take the time to scan the QR code and let us know how familiar you all are with results-based accountability. We'll just give that a second. That we still got some responses coming in. Okay, we're going up on the scale, 6.8. We'll give it another 10 seconds. Okay, looks like we're about 6.4. So got some good understanding of RBA, but certainly maybe an opportunity for us to expand that knowledge on results-based accountability. So thank you all for sharing where you all on the spectrum of knowing about RBA. So we'll move on to the next slide.
That's insane.
So in today's objectives, we have 2 objectives for today. So we'll explore how results-based accountability, or RBA framework, can support hospitals in designing and executing a data-driven and outcome-focused CHIP, or community health improvement plan. Secondly, we'll foster collaboration and information sharing amongst hospital participants to build and support a network for addressing common challenges and opportunities in the CHNA and CHIP process. Next slide. I'll hop right into things. I didn't even introduce myself. So I'm Monty Robertson, the Executive Director of the Alliance for a Healthier South Carolina, which is the organization that convenes and connects diverse stakeholders to align and catalyze efforts to improve the health of communities in South Carolina. And so one of the ways that we're doing that is aligning, again, that state efforts and community efforts. And we're building this through our infrastructure and capacity building initiative called Collective Impact in Action, Partners Aligning for Community Health. So real quickly, before we get into the bulk of our meeting and why we're here today, I want to give you guys an overview of really the statewide effort to align efforts and how we're doing this. Next slide. So we're partnering with several organizations to build out this capacity and this infrastructure, which I'll go through those 4 objectives. But as you can see, it really takes a big group of people to actually, in different organizations, to make this happen. So we have South Carolina DPH, the Hospital Association, Center for Applied Research and Evaluation. We have SCAHEC, the Office of Rural Health, and Furman University's Institute for the Advancement of Community Health as our key partners in this work. Next slide. So I shared this with you all if you were on the first webinar, but we have 4 objectives in this work. Number 1 is building a forward-facing dashboard. I know a lot of you on your community health needs assessment need access to data. And so we're partnered with Department of Public Health to build out a data dashboard. Hopefully in the next couple months, we'll be able to release that so you all have easily accessible data for your community health needs assessment, but also to understand the status of the communities that you all serve. So we'll have that up and running in the next couple months. Secondly, which is what we're focused on today, is really the community health needs assessment and Community Health Improvement Plan. And so we're working with Center for Applied Research and Evaluation out of USC and Furman University's Institute for the Advancement of Community Health to help develop a statewide and collaborative model for community health needs assessments and improvement plans. And then the second two really build on the first two. So through building our capacity and knowledge, our results-based accountability. Again, we'll be covering that today. It will give us an opportunity to strengthen and align this work across the state. So we'll get into, again, all the details of that and how you all may be able to take advantage of some education around results-based accountability. And then lastly, having this software or tool to actually manage our improvement plans across the state. So this will give us a much more robust way to actually understand what's going on, what are the key activities, initiatives, and programs that are supporting health improvement across the state, and how do we leverage, spread, and scale these different initiatives to improve health of communities in South Carolina. Next slide. So we'll jump into our first presentation with Dr. Melissa Fair, which we've had the privilege of working with, really examining the needs assessment process. And so Dr. Melissa Fair is the Director of Community Action at Furman University Institute for the Advancement of Community Health. Melissa leads the research and evaluation strategy for the Institute, supports community and clinical partners in the implementation of evidence-based interventions, and maintains statewide relationships to advance and align community health initiatives. She also serves as the principal investigator for Live Well Greenville, which is a local healthy eating, active living coalition, where she oversees strategic direction of its evaluation activities and the coordination of multidisciplinary team of researchers from Furman, from Clemson, and USC. She's a Greenville native and a fellow Furman alumni. She
Go
also
Dens.
Go Dens. She also received her PhD from the University of South Carolina Honor School of Public Health. So Melissa, I'm going to turn it over to you.
Thank you, Monty. So as Monty mentioned, I'm Melissa Fair from the Institute for Advancement of Community Health. I am presenting on behalf of also my colleague who was part of this work, Pam Gillum at the USC Center for Applied Research and Evaluation. I'm trying to get to my presentation screen. Okay, there we go. So some of you may have seen the last webinar in this two-part series where Pam talked a little bit about the high-level overview of this work, but just wanted to give you a brief refresher. As a reminder, the work that Pam and I are doing around a CHNA CHIP assessment is aligned with the Objective 2 or Goal 2 of the grant initiative, which was to develop a model for statewide collaborative community health needs assessment and community health improvement plans. So we are focusing there, it's a three-step process, but today we are focusing on results from the middle process. So we did that cross comparison of CHNA methods and instruments. We're going to have a complete report that we're going to be able to share with the Alliance and the community here in the next month or so. We also did interviews with the staff who were responsible for the CHNA and CHIP, and also interviews with health system executives. And today we're focusing on the staff interviews about the CHNA and CHIP. So 6 healthcare systems participated in those interviews, and you see that list here. We covered a wide range of topics, including why they did a CNA, their process for collecting data, analyzing data, how they developed their community health improvement plan and allocated resources, engagement of partners, value or perceived value of a statewide collaborative strategy, and their knowledge of Live Healthy SC, which is the state health improvement plan. And First, we're going to talk about the barriers and challenges that the health systems noted in their work. One of them being, probably not surprisingly, is finances and resources. And you can see here, there are representative quotes on this screen. And one of them was just not having enough resources in the budget, that they were reliant upon internal staff and internal capacity, that this wasn't a budgeted line item. And so, for example, here you can see one system noted that they had to give up a position in order to get this done if they wanted to bring an outside consulting firm to support the work. And it took about 6 months to make that happen. And so they were behind the 8 ball from the start, which put them in a bind. So resources also limited the selection of priorities and strategies, because health systems didn't want to select strategies that they knew that they didn't have any resources to implement. So they were careful about committing to things that there were no funding for, but then they also noted that they walked that tightrope, you can see there, of not wanting to create goals and strategies that were not meaningful just because there was no money to support them. And so had to be very thoughtful in terms of what they were selecting as priorities and strategies as a result of that. I think someone might have muted me somehow. Can y'all hear me?
Yes, we can hear you now.
Okay.
So other challenges were staff capacity. So healthcare systems, as noted, because of limited resources, were often dependent upon existing staff to collect their data. And because this wasn't people's primary roles, they only had limited time to give to it. So I think someone else might need to mute. So you can see here that it was a challenge that was difficult to overcome because they had a small team, and so they had to be more people charged to make it a priority. Another noted problem was that staff were often redeployed to other things as other issues came up or health system priorities changed or shifted while they were doing the CHNA. So they had to balance the competing roles and demands of the staff that were
You were muted again.
So barriers and challenges also include time constraints. So they noted that it limited their ability to collaborate with other systems and partners. And so you can see here that this system was not opposed to collaborating with other healthcare systems, but the timing made it difficult. Their things were often due before the other health systems were due, so they had to get started sooner, and so limited their ability to engage health system partners and community partners. Another time constraint challenges were getting the resources approved, if they did have resources to implement the CHNA, because that had to go through several layers of administration. And if that wasn't a priority of the highest levels of administration, it resulted in major delays. And you can see here, this health system was about 6 months behind. They were ready to get started, but didn't have the approvals that they needed to invest resources to implement the CHNA. Another thing that we saw that was a common theme across all of the health systems was representativeness of data and concerns about how to get the data that was representative. So when I talk about representative, I mean, does the data represent the community that you're collecting the data from? So does your CHNA data look like a microcosm of the community that you're in, whether that's by race, ethnicity, whether it's by gender, whether it's by age diversity, economic diversity, educational diversity. So this system, you can see here that they did look at the breakdown to try and make sure that the data was representative. And they did try some strategies to increase the diversity of answers or people responding. But in the end, they still found that they were not representative of their community. And another system noted that they looked at what their racial and ethnic makeup of the survey respondents were and found that they didn't have enough Hispanic input. And they hypothesized that it might be that because the Hispanic community was less reticent to share or more reticent to share information. And so they had to be creative in thinking of strategies to reach that community. And you can see here, this other one said they also struggled to get different economic populations and responses from people of color, and it was really, really tough to get that. So in addition to the CHNA itself, we asked a lot of questions about the CHIP, or the Community Health Improvement Plan, which is the second part of the process, and saw that a lot of times what came out of the community was not necessarily things that fell directly into the wheelhouse of the health system. Communities identified complex challenges such as lack of affordable housing or food insecurity or obesity or substance use disorder. And these are health issues or social determinants of health that, because of their complexity, are also going to require complex solutions. And that didn't always mean that the health system should be the person responsible for. And so you can see here that this health system decided to identify champions to really lead and guide the work. And when they were doing the CHNA and the CHIP, they needed someone responsible for that work. And so although they were internally responsible, they realized that they were not the expert in the priority area. And so they had to work with a champion or a community partner if they were going to adopt that challenge. Another one was, how do you sustain engagement and buy-in both internally and externally? And so here we saw that they thought community engagement was hard because the process was so slow. And so they really wanted it to be a shared community health improvement plan. But as time went on, it felt less and less shared. And ultimately, the health system was the one responsible for it. So they recognized that they needed to have systems in place to strengthen their relationships and make it feel like a shared endeavor. And so it hindered them from keeping their momentum going. A wrong title here, but this one is, they lack systems of accountability and ways to track progress. And so once you've collected your data and once you've prioritized your data and identified your strategies, now what? We found that some of the systems felt like they lost momentum, or that there was no way to be accountable to the community partners and report back to the community partners. And that linked back to that challenge of sustaining the engagement and momentum. And so this health system noted that they didn't have a shared measurement tool for those goals, and that they know that they need that next time. They actually mentioned specifically that they needed to get trained on results-based accountability. Some other challenges that we saw was there's a lot of wide variability in the CHNA itself, as well as the prioritization process. So some systems are doing a lot of work that is more coalition-focused work, and their CHNAs and CHIPs are community-owned. Others really did this as an internal process and said they felt like they were struggling with that it was a box-checking mentality of just needing to get the CHNA done. Others we saw that helped some also who got to make the decision based on the data of what the priorities were. Some health systems felt like that they had a very top-down, administration-driven approach where they got to share the data with leadership, and leadership made the decisions without their input or the community partners. Other health systems chose an opposite approach where they felt like the data and information, and therefore the strategies, really bubbled up from the community. And so that's where the priorities came from. Many systems noted challenges in getting buy-in from leadership and the importance of the chip. And so the people actually doing the CHNA didn't want it to be a box checking mentality, and so wanted to see those strategies happen, but needed the support from their leadership to do it. Many systems also lacked internal funds or grant dollars to support their implementation strategies. So when we look at all of this, what are some of the preliminary recommendations based on things that some of these came out of the health systems themselves, because in addition to barriers, there were also many noted successes, and then also looking at other ways that hospital systems across the nations have done CHNAs and CHIPs effectively. So some of the most effective partnerships treated a CHIP and a CHNA like a cyclical iterative process rather than standalone CHNAs and CHIPs that needed to be done every 3 years. So it was a living and breathing document that just got updated along the course of 3 years, and then new data was collected the next time that it was due. And so that created accountability for following strategies and implementation over time, because especially when you're picking a really complex idea like, reducing substance use disorder in a community, you're not going to achieve all of your goals in 3 years. Most of the effective partnerships engaged a wide array of partners in all parts of the CHNA and CHIP, not just single components. And they engaged traditional and non-traditional partners in the process. So community members, people with lived experience or patient experts, academic partners, FQHCs, nonprofits, free medical clinics, et cetera. So, and also the most effective partnerships engaged those partners in the entire process. What we found is that a lot of health systems do engage people in getting input for the data collection and then start to lose momentum, and there's less and less engagement over time as they move into prioritization. And then finally, selection of strategies and implementation of strategies, engagement of those partners tend to wane. Creating metrics of success and accountability. So that means that the goals that you select or strategies you select as part of your prioritized items need measurable, like if you're going to do this many learning opportunities in the community, you're going to increase access to trails by this much. Having a concrete metric of success, a way of sharing your progress towards that success back with your health system, as well as all of your community partners, was really, really important to creating and sustaining engagement. We saw that health systems that were able to leverage their academic partners for data collection strategies had less concerns about the representativeness of their data. They were able to work with those academic partners to do things like come up with a sampling plan. And when I say a sampling plan, that means we look at the demographics of your community and we say, you need this many surveys total, you need this many from this demographic, and this would make sure that you have a sample that's representative, not just of the patients you serve, but the community at large. The most effective health systems, also in the literature and in this process, identified and cultivated champions for their prioritized strategies. And they had champions at multiple levels. They sought buy-in from their C-suite, management level, also boots on the ground staff, community, et cetera. Some systems noted that it was more effective in getting C-suite management where they could align the implementation strategies with internal system goals. This didn't mean that they just picked the things that the system was already doing. This meant they looked at the things that the system was doing and said, do those align with the strategies that we could be doing, and that created buy-in from C-suite and management. Also opened up potential funding streams for some of the healthcare systems because administration had already put those items in the budget. Identify community partners. So not only do you engage your community partners in the process, but they actually have action items that they're responsible for on the chip itself. So if you're working to improve affordable housing in your community, the health system shouldn't be the only person owning that, should also be working with your local government, nonprofit stakeholders that work in housing security, and other community stakeholders. And then lastly, work with leadership and community partners to identify potential funding mechanisms, such as grants, to support resources to implement the CHIP strategies.
You're muted, Monty.
You'll think I would have this thing figured out by now. But no, thank you so much, Melissa, for this incredible insight that you've provided. I think the insight that you have provided aligns nicely with the infrastructure that we're trying to build within the state, the education that we're looking to provide across the state utilizing RBA. And so I think we'll see that through Landon's presentation, give us a high-level presentation on what results-based accountability, this framework that I think will be certainly very beneficial to organizing your community health improvement plans. So I'm going to turn it over to Landon Campbell, who serves as program manager for the Alliance and oversees our Collective Impact and Action Initiative. So Landon, I'm going to turn it over to you. And before you start, Landon, if you guys have any questions for Melissa, please add us to the chat box, and we'll try to get those addressed. Landon, turn it over to you.
Awesome. All right, thank you, Monty, for that introduction. So like you just now stated, I will be covering the bare basics of results-based accountability over the next couple of minutes. And as you also stated, please add any of your questions that you may have during my presentation or the following presentations to the chat so that we can check on those at the end of today's webinar. So let's go ahead and get started. So before we dive too deep, I'd like to share the basics of RBA as a concept. RBA is a disciplined way of thinking and acting to collectively address complex social problems and create measurable change within organizations and communities. It is a wide variety of uses and can be utilized as a tool for CQI internally within a single organization, as a tool to drive meetings, or as a framework for larger efforts, including collaborative actions within coalitions. RBA is a framework that capitalizes on ends to means thinking and uses data-driven decision-making processes to help communities and organizations take deliberate action to solve problems and improve performance. You'll begin the RBA conversation, regardless of your use, with the end result that you hope to achieve, and you'll work backward to define how you will address the issue at hand. And we will dive deeper into this in a few slides. So finally, RBA uses common language, it uses shared measures, and assigns responsibilities to achieve a collective impact on shared goals. The framework emphasizes a need for effective communication between participants as well as the intended audience for your plan. Everyone should end up playing from the same sheet of music by the time you are done with this process framework. So there are three key components to RBA that I want to touch on during our meeting time today. The first of these is the idea of population versus performance accountability. So population accountability is the accountability on the macro scale. So it'll go beyond the population you'll be able to affect as an individual organization or coalition, and will encompass an entire population instead. So you will have a part to play with population accountability, but it won't fall solely on your shoulders to affect change at this level. So we associate two measures with population accountability, and I'm briefly going to touch on both of those using our newest state health improvement plan for examples. So first, we have our result statements. These statements are blanket statements of improvement that on that same macro level scale as population accountability. So all people in South Carolina achieve and sustain generational economic prosperity, and all people in South Carolina consume nutritious, affordable food are two prime examples of result statements. These result statements do not follow SMART goal principles, but are worded more like the vision of an organization. So they're not really going to have a time limit attached to them or so forth. Now, next we have our indicators. These statements give context to those result statements and show measurable change over time. Indicators are usually shown as rates or percentages and should be pulled from data that is regularly updated for the population of interest. For our nutrition-related statements or result statements, indicators could include the percent of residents in South Carolina experiencing food insecurity or our fruit and vegetable consumption rates. So on the other hand, performance accountability focuses on the specific target audience or those that your program service directly. So you'll have a key role in the responsibility of improving the outcomes for this specific population. The idea behind RBA is to better define what we are responsible for and also help rein us in from making broader promises or statements about the reach and effectiveness of our programs. So for example, if your program or service covers at-risk populations in Spartanburg, South Carolina, changes occurring for these residents would fall under the realm of performance accountability. The well-being of all at-risk populations in South Carolina as a whole would fall under population accountability. So the goal is to push you and your partners toward creating refined, actionable steps that target these direct recipients of your services. So the second key concept of RBA is how we aim to define our performance measures. Effective measures should cover three key questions. How much did we do? How well did we do it? And most importantly, is anyone better off? For this first question, measures that record the quantity of our effort can be used. Measures that speak to the quality of our efforts kind of answer our second question here. And finally, measures that speak to the quantity and quality of our intended outcomes for the target populations answer that third and final question that you see in the bottom two quadrants on our screen. So most of our common measures tend to cover these first two questions and really help us to understand how efficient our implementation phase was. But we want to make sure that we include some robust measures that fall under that third question so that we can actually see how our implementation plan affected our target audience. Similar to what we discussed in the last slide, we want to be sure that these measures focus on our direct population of interest and not whole populations. Now, unlike these first two concepts, our final concept covers the actual process for making your action plan within the RBA, and it is referred to as the turn the curve process. This process consists of 5 cumulative questions that should help you with your planning stage. The first of these questions is, how are we doing? For this question, we want to dive a little deeper into the result of interest and its associated indicators to find trends and get a better understanding of if we're moving in the right direction or not. So turning the curve refers to turning these trends in the direction we wish for them to go. Our second question covers the why behind these trends. So you and your partners will want to dive into the contributing factors related to these trends you considered from question 1. These questions utilize both quantitative and qualitative information to better understand why things are the way they are, and may also provide insight into how the trend will continue if we don't do anything throughout the future. The third question focuses on who needs to be at the table to address the context that we started to put together in these first two questions. So this includes consideration of our traditional partners, as well as those non-traditional partners, and strategies to garner participation where needed. So making sure that everybody is at the table that needs to be at the table for us to address our results of interest. So for question 4, we will want to brainstorm potential strategies that could help us to get our trend from question 1 going in the right direction. So those indicators that we just talked about and their trend lines, making sure that we're going in the right direction there. We'll want to look at best practices, low to no cost solutions, off the wall ideas, and innovations, and narrow these down to the most feasible in our specific context. And finally, we will take the context provided from the first 4 questions to actually write our action plan for question 5. This step will assign strategies from question 4 to the partners that we have identified in question 3, and it should help us to clarify roles throughout the implementation phase. Now, it is worth noting that this is an iterative process, and you'll want to consistently revisit this turn the curve process as you progress through implementation. And the idea is that it will continually improve on your action plan as you do so. So to put everything together, let's think of these concepts in one cumulative diagram. At the population accountability level, we have our high-level results and indicator statements. These statements guide our first turn the curve activity and will lead to the overarching strategies for that our full group agrees on. These high-level strategies include actions that systems, organizations, and programs within our partnership list will have a hand in, but our programs will not have the sole responsibility for implementing them all. So at this point, these individual entities can go through the same turn the curve process a second time and take these high-level strategies and break them down further into workable components with associated performance measures. So those are the ones that you're actually going to be fully responsible for as a program or as an organization, so forth. And the turn the curve activity is usually performed at least twice when going through the population to performance accountability, and you'll end up with an action plan that should be feasible based off of your specific capacity and resources and who's at the table. So as I mentioned in my introduction, I was only able to give you guys a really brief introduction into RBA this afternoon. I know we got some time constraints as far as the rest of our webinar is concerned, and I don't want to run us over. However, we do have a partnership with our friends at the South Carolina Office of Rural Health and SCAHEC that we basically help to create a robust training opportunity that is free for participants. And this training really consists of two key components. For the first part is an online module component that is self-paced. So it will take you through a much deeper dive of what I've went over today, and it will teach you a little bit more about the basics of RBA and how to implement it within your specific context. But part two is really more of an in-depth, in-person interactive workshop. So this workshop builds on these basics and will take you through an actual implementation example utilizing RBA. So the full turn the curve activity, you're going to be able to actually understand how that works in context. So please note that if you wish to take the training workshop, so the in-person component, you will have to complete the online modules first. And you also need to indicate what type of continuing education credits you wish to receive for both portions of the training when you sign up. We do offer continuing education credits for these trainings. Dates for the upcoming in-person workshop can be found through the QR code on this slide, and you can register for the online modules here as well. So we'll have this available afterwards, and you can also take a second here and either scan the QR code or look at that link that we have on the screen if you are interested in these trainings. But with all of that, thank you for your time today. And at this point, I'd like to turn it back over to Monty to continue our webinar.
Thank you so much, Landon. I know 10 minutes does not do justice in going over RBA, but again, please take advantage of that opportunity. Want to thank the Duke Endowment for providing funding to actually provide that training free of charge across our state. So we are, as a state, spreading this framework where we have utilized it for the State Health Improvement Plan. And we have several community coalitions and some hospitals that are getting on board with utilizing this framework as well. So please take advantage of that, get that free training. So with further ado, we're going to move on to our next agenda item where you guys have heard the concept, but now we will actually take a look into an example of what this looks like in action. And so we have invited our friends from North Carolina who are also doing this work in our neighboring state to provide us with an example of how they're utilizing RBA in North Carolina. So today we'll have Maddie and Quatavia with us. So Maddie is a recent Master of Public Health graduate from the University of North Carolina at Charlotte. In January of 2024, she joined Eastern Area Health Education Center, AHEC, as a community health improvement consultant. And then we also have Quatavia White, who is a community health improvement coordinator at ECU Health, where she leads Clear Impact scorecard development to enhance community health across Eastern North Carolina. So I'm going to turn it over to you all. Again, if you all have any questions, please utilize the chat box. But without further ado, I'm going to turn it over to Maddie and Quatavia.
Awesome. Yeah, thank you for inviting us to share a little bit about the work in North Carolina. So just to kind of set the stage a little bit. So the work that I do is really centered around training and technical assistance. And then we'll dive into the example from a health system with Quatavia. So going back a little bit, North Carolina has plans that are put out every 10 years, and those are really similar to y'all's state health improvement plans. We have Healthy North Carolina 2030. Those began in the 1990s and really with the overall goal or result of making North Carolina a healthier state. And so we move fast forward a little bit to 2011, where in this health improvement plan, there were 13 focus areas and about 41 objectives and targets that we were hoping to meet in 2020. Moving forward a little bit, that plan has definitely gone through iterations and continued to be like a quality improvement project in itself. And so now we're looking at Healthy North Carolina 2030, where we have identified 21 of the wicked problems that North Carolina is facing. And we're really looking at these as a way to not only center the work that's being done across the state, but really show that alignment piece through implementing results-based accountability trainings and framework and technical assistance, but also using that clear impact scorecard, which I'll talk a little bit about today. So within these 21 different wicked problems, you see things ranging. We have like poverty, unemployment, sugar sweetened beverage consumption. We're talking about teen births, HIV. So a whole wide range of different health issues that we're talking about at the state level. And so really being able to use this as a way to guide the work that's done at a local level. So North Carolina is a little different. We have health departments in each county. And so we have 100 counties in North Carolina, about 86 health departments. And so the health departments are the ones that are really leading the work in terms of community health improvement plans. And those are also partnering with the hospital systems, Healthy People, Healthy Carolina coalitions as well. And so this is a way to bring these health topics and then talk through who's implementing that results-based accountability framework that you heard Landon mention a little bit, but then also when we're talking about transparency and showing collective impact and talking about accountability, this is where in North Carolina, we're really leaning on scorecard and the use of clear impact scorecard across the state. So the use of scorecard really started within western counties in North Carolina. And now we have, like I said, all 86 health departments, all 100 counties are using Clear Impact Scorecard to document their work. And then we have a lot of the health systems as well that are using that to document their community benefit work. And so this is something that's recently a new addition, which is the work from the Healthy People, Healthy Carolina coalitions. And they're also using scorecard to really, again, show this collective impact piece, talk about alignment and how we can all really work together in terms of resources and what's being done in terms of different strategies and programs to better move in one direction rather than everyone kind of doing their own thing in their own spaces. And so the alignment and collective impact piece, like I said, is really grounded in that Healthy North Carolina 2030 or that state health improvement plan with those 21 different wicked problems. But the work and those health outcomes are really addressed, like I was saying, in the state health improvement plan. We have community health assessments that are done at that local level, those leading to the community health improvement plans or the community benefit work for the hospital systems. That also working with the health departments, the hospital systems, and those Healthy People, Healthy Carolina coalitions to really, again, show that collective impact of if we all have the same priority area, how can we better align our strategies, our programs, and our interventions, not only with what the state is doing, but us as 3 different entities as well. And so thinking about how this works in terms of results-based accountability and also the clear impact scorecard and rolling that out. This is where my role is really heavily concentrated on in terms of the training and technical assistance piece. So like Landon and Monty mentioned, I'm with Eastern Area Health Education Center, and I've been there about a year. And so really this work, one of the main roles of this is that one-on-one technical assistance. So if there's a hospital system or a health department or a community coalition that is wanting to get in and use scorecard, we're able to provide them one-on-one assistance so that they're not just going in and trying to figure out the system on their own, but really having that work grounded in the results-based accountability training and framework, but then having that one-on-one help and support to really make sure that they know how to navigate scorecard and know how to upload different documents and know how to organize their work in scorecard as well, but then also serve as the sort of middle person in terms of getting different counties connected. So if we have a health department that's using a scorecard and a hospital system, there's ways that those things can be shared. And again, talking about that collective impact piece. Other sorts of training and technical assistance that are done throughout North Carolina. The first one with the Community Health Assessment Institute, that's something that's relatively new. We got some funding from Duke Endowment as well to assist with, if we're talking about a comprehensive community health needs assessment in the state of North Carolina, what does that look like? What does that process look like? And really wanting to bring that alignment piece as well to the community health assessments. So we have an institute that's done twice a year. And we've done about 2 of those so far. Our next one's in the spring. And then we have scorecard school. So that's something when we're talking about the use of clear impact scorecard and connecting that back to results-based accountability. We have sessions throughout the year that are really focused on specific parts of building the scorecard. So the scorecards for the health departments are really looking at their community health improvement plans in there. So having sessions geared on how to set up and navigate the scorecard, how to put your community health improvement plan into scorecard, what that looks like. And that really helps in terms of having a similar framework and setup so that all the health departments have a similar way of viewing the scorecard and setting up their scorecard for different accreditation purposes as well. I'm not going to spend a lot of time on the hospital systems because I'm going to pass that over to Quatavia in a moment. But then also, like Monty and Landon were talking about, you all have the opportunity to participate in some results-based accountability trainings. And I really think that that is one of the first pieces that really helps this work move stronger together when we're talking about accountability and transparency and collective impact. Because if you all are able to think about results-based accountability as really that level setting piece of getting everyone on the same page and setting the common agendas and just having common language to talk through all of the different strategies and implementations and programs and things, then that also helps the transition into scorecard and documenting it that way a little easier, I think, too. So those are sort of the buckets of training and technical assistance. And then one of the things that also came out of this work, which is one of the last things I'll talk about, is the North Carolina data portal. So I heard at the beginning of the presentation talking about a central place for secondary data and building that out. That's something that is new to us as well. And so we're going through different phases of building out the North Carolina data portal so that we have secondary data available at the county level. We have different maps and things in there to where if a health system wanted to look at all the counties in their footprint, they have the opportunity to do that too. And all of this really coming from addressing the gap in terms of secondary data, having that be readily available, but then also making sure that those are things that, along with being readily available, are also helpful for that comprehensive community health assessment. So, quick overview of the high-level work being done as far as training, technical assistance, and where we're at in North Carolina. I'm going to pass it over to Quatavia to talk more on the hospital system side. But yeah, thank you all, and let me know if there's any questions in the chat.
Thanks, Maddie. Again, hey everyone, my name is Quatavia and I work with ECU Health. Today, let's see, there we go. Okay, just to give you an idea of who we are, ECU Health is a health system covering Eastern North Carolina. We have 9 hospitals and we cover a 29 county region. Today I'll really be focusing on ECU Health Medical Center, which is one of the 4 teaching hospitals in the state of North Carolina. We'll look at our scorecard, our implementation strategies, or the CHIP, as well as PIT Partners for Health, which is a HPHC coalition that Maddie mentioned earlier. So previously, whenever we did our community health needs assessment, we documented our plan, which essentially became a PDF document that we stored on our website. Taking a closer look at it, you can see how it's just a list of strategies that say or document what we plan to do based off of the data we received from our community health needs assessment. But by using the scorecard, we're able to take this document and really turn it into a living, breathing website that really kind of shows what we're truly doing in our community. So here, displayed here, is just an example of one of our programs, Coordinated Approach to Child Health, where you can see what we've done over the past 3 school years. But however, it did take a little bit of time to go from that paper document to a living, breathing website. And we did that really in just 3 steps. Our first step really consisted of exploration and education, where we worked with each of our community partners in our hospital or those who are doing outreach events, and really just learned about what they were doing, and then educated them on scorecard or on RBA. Our second step was really looking at or evaluating what they selected and modifying the performance measures they selected as well. And our third step, we analyzed the data, and lastly, we'll tell the story behind the curve at the end of our CHNA cycle. And that's really just turning the data into a story and telling what it's showing us. So in step one, we created an RBA tool. I know Landon mentioned this earlier, and I won't go into too much detail, but we wanted to really educate all of our partners on what was RBA, and we knew it wasn't feasible to really send everyone through the RBA training. So this document really helped them figure out what the different types of performance measures are. Once they went through the education piece, they created their own performance measures. Again, here, the top right corner gives you examples of types of measures, and the bottom was where they were able to kind of input the data that they were already collecting. Again, ideally, we know that better off measures really tell us if we're doing what we intend to do in the community and people are really better off. So that's why that one is indicated with 3 stars. From there, we took their measures they created and put it into an Excel document. This step was really optional, depending on if you want to give everyone access to scorecard or not. But in our hospital system, we felt that this would be the easiest way for them to just submit their data to me each quarter or each year, and from there we take and add it into our scorecard. So, kind of going from the Excel document to scorecard, this is how, or in this example, our cancer prevention team's work looks like in scorecard. Again, you can kind of divide the various either screenings or whatever the specific measures you guys are using into subcategories, and kind of display your work there. So there's a few different reasons that we use scorecard, and I'll go through each of these over the next few slides. So the first is transparency. We're really able to use this platform to tell the community or show community what we're actually doing across our county. Next, we go from displaying kind of our PDF version of our implementation strategies to actually having a living, breathing document. Next, we're able to track our county level indicators. And these, as Landon mentioned earlier, are kind of just statistics that measure how well or what the health condition is in our county. This could be either life expectancy, uninsured rates, or even obesity. Also, you can kind of look at how you've been doing in the past to see where you're projected to go. And in this example, a county might say, hey, what happened in 2016? You know, our suicide rate was really low here. So we might want to kind of duplicate that again and see if that helps us kind of bring that rate down. Lastly, we're able to connect with partners to share our work. Here's actually a screenshot from our county health department scorecard, but you can see here in the beside those performance measures, you'll see EC Health and PPH, which is our community coalition, and it kind of just shows how we're able to connect our work laterally as well as upward. So all of our hospitals are able to kind of connect their scorecards to our larger ECU Health system scorecard. And just some tips or next steps for people that are interested in taking or utilizing this platform. Really be patient. It did take a while to go from that paper document to using scorecard. Definitely set goals for completion and offer a supportive culture for those team members who may be new to this type of data collection and just kind of showing they work this way. Use your state resources. In this case, we had Maddie to help us. Start with internal partners who are already doing the work. This may look like partnering with your county health departments that already have their scorecards. And lastly, just really starting with RBA mindset when developing your implementation strategies. For us, we definitely wish we could have had the opportunity to do that, but we started working in scorecard after we had already completed our CHNA process. But we're looking forward to the next cycle and looking for it to be a lot more easier. And with that, I'll turn it back over to Monty.
Thank you so much for that presentation. I was looking through the chat box. I see one question asking about kind of funding and essentially how do you guys pay for this first scorecard for your hospital system?
Luckily, or did you want to take this, Maddie?
I was gonna say, so that's an interesting question. It's gone through quite a few different funding opportunities. And so the first, like I was saying, the scorecard started in Western North Carolina with about 15, 20 counties. And so then it started growing, and we knew that it would be something that would be effective and efficient as far as community health improvement plans. And so in terms of the state of North Carolina seeked funding from the Foundational for Health Leadership and Intervention, and that was funded for a while. And now the scorecards for all 100 counties are being funded by the Duke Endowment or the state of North Carolina.
Great, good question. Just to give you guys some clarity about kind of South Carolina's next move when it comes to scorecards. So currently, we're building scorecards for the priorities that have been identified for the State Health Improvement Plan. We also have partnered with Healthy People, Healthy Carolina to pilot utilizing scorecard at the community level. So we'll start with some community coalitions and fine-tune what that process looks like to get community level organizations on board. And then next will be, of course, incorporating hospitals into this process for now. But the initial investment, just like North Carolina, comes from the Duke Endowment. Let's see, I don't think, do we have any additional questions, Tashina or Landon?
See any in the chat at the moment?
Yeah. Great. Well, thank you so much, presenters today. I know we covered a lot of information, but we wanted to utilize really just two-part series to start engaging our hospital systems and other partners who play a role in the community health needs assessment and improvement plan process. So thank you all for being here today. As far as next steps, so Duke Endowment has been gracious and has awarded us some additional funding support to continue this work. So we'll be working, the Alliance partnered with the Furman University's Institute for Advancement of Community Health and the Center for Applied Research and Evaluation to develop a kind of learning community or for hospitals and other partners for the community health needs assessment and improvement plan process. So more information to come out here very soon about that process. Attached to that, we're also working on a standardized survey, community survey questionnaire. I know many of you all have asked about that. We do have a first draft and are reviewing that, and certainly will be in a position here soon to be able to utilize that, or for you all to utilize that for your community health needs assessment. So stay tuned for that as well. And I mentioned also that we are working on that data dashboard, so you all have access to secondary data. So there's lots of different components that we are working with many partners to put together for you all to make this process more efficient and effective in serving the communities across South Carolina. And I think we had a couple more reminders before we closed out. The first reminder is we have our annual Health Equity Summit, which is a day-long summit in Columbia on April 17th. So we encourage you all to check that out. You can visit our website at healthiersc.org, or again, scan the QR code. We would love to have you guys attend that conference. It's an awesome conference that attracts 250 plus people every year. So come check that out. And then one more thing, we have an evaluation. So we want to get you guys feedback. We want to know, how do you think this webinar went? Any additional topics that you guys want us to cover? How can we make this a more meaningful and informative experience for you guys? So please take the opportunity to complete that evaluation. So with that said, I think that concludes our webinar series. Thank you all for attending today. Oh, one more thing, sign up for a newsletter. You can go to our website, sign up for that to stay informed on upcoming events and updates as well. Or if you have any questions, please email us at alliance@healthiersc.org. With that said, thank you all for attending, and we look forward to continuing working with you all. Have a good afternoon.